Today, buprenorphine for opioid use disorder, Suboxone, Sublocade, and the 2026 treatment landscape. Buprenorphine for opioid use disorder, what clinicians need to know. Buprenorphine is a partial agonist at the mu-opioid receptor, about 40 to 50% the activity of a full agonist. This creates a ceiling effect. Respiratory depression plateaus at doses well below fatal, making it safer in overdose. Buprenorphine also blocks kappa receptors, which may reduce dysphoria and stress-driven craving. The combination makes buprenorphine a first-line treatment for OUD. It reduces withdrawal and craving without producing the full opioid high. Suboxone combines buprenorphine with naloxone in a sublingual film. Naloxone has low sublingual bioavailability. It does not affect buprenorphine when taken as intended. But if someone injects it, naloxone precipitates acute withdrawal. This deters injection misuse. Dosing starts at 2 milligrams and typically reaches 8 to 16 milligrams daily for maintenance. The challenge: daily dosing requires adherence, and the medication can be diverted. Sublocade is a monthly extended-release buprenorphine injection using the ATRIGEL system, a polymer gel depot injected subcutaneously, releasing buprenorphine steadily over 30 days. 2 maintenance doses, 100 and 300 milligrams monthly. Patients must already be stabilized on transmucosal buprenorphine before switching. The key advantages: no daily dosing, no diversion risk, and consistent plasma levels. Administered in clinic, adherence is built in. Buprenorphine is DEA Schedule III. As of 2023, the X-waiver was eliminated. Any licensed clinician can now prescribe it for OUD. Compare this to methadone, which has a separate REMS with cardiac monitoring for QT prolongation. Buprenorphine has no equivalent cardiac REMS, making it more accessible in primary care. Induction: patients must be in moderate withdrawal before the first dose. Use cows or sows to confirm. Starting too early risks precipitated withdrawal. Start low, 2 to 4 milligrams, titrate based on effect. Drug interactions: benzodiazepines and other CNS depressants significantly increase overdose risk. Counsel patients explicitly. For Sublocade, switch only after stabilization on transmucosal buprenorphine. The first injection happens on the day the previous formulation is stopped. No overlap required. Key differences: Suboxone is daily, patient-administered, with naloxone to deter injection. It relies on adherence and can be diverted. Sublocade is monthly, clinician-administered, with no diversion risk. It requires patients already stabilized on buprenorphine. Neither is universally better. The choice depends on adherence history, diversion risk, and clinical context. 3 takeaways. Buprenorphine's partial agonism gives it a safety ceiling. It is a first-line treatment for OUD. Suboxone and Sublocade address different needs. Suboxone for patients who can manage daily dosing. Sublocade for those needing clinic-based administration with no diversion risk. The X-waiver removal expanded access. More clinicians can prescribe, but DEA Schedule III obligations and state regulations still apply. Questions about today's content or topics you'd like to see covered in future episodes? Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.